I'm going to suggest that you all stand and stretch while I make a very slow announcement so you have time to get. So if you aren't familiar with how things are done at the Colorado Health Symposium, you should be writing your questions down on the cards at the table and passing them to the aisles, and we'll do it again after our last morning speaker, and we'll compile them and bring them together to do our Q&A session. But now that you've stretched and relaxed, let me move us to our next presentation from Ivor Horn, the Medical Director of the Center for Diversity and Health Equity at Seattle Children's Hospital. This was not a break, this was a stretch. Time to recenter. Another pediatrician, she's a professor of pediatrics at the University of Washington School of Medicine. And so now that your brains are flowing again, please join me in welcoming Dr. Ivor
Horn. Thank you so much. It was a pleasure to meet Alan and to hear his presentation this morning, because I just met him this morning, but we are definitely kindred spirits. It was great to hear that and be motivated. Whenever I give these presentations, I am always sort of prepared to give a talk, and then what happens invariably is things change, and I hear great things the day before, and that means my presentation changes. And so I want to start this presentation by thanking my PowerPoint connoisseur, my husband in the background, because he's the one who has to deal with these changes late at night. because like Alan, I would much prefer to not have anything and to just have a conversation. So we heard a wonderful story today, and I'm going to start a little bit with a story as well, because we're telling stories today about connections and why it matters and how it makes a difference. So I was really pleasantly surprised to hear that Alex Drain's father was from Jackson, Mississippi. I am from Jackson, Mississippi, and I have seen her in many conferences, and we have spoken many times, both virtually and in real life, and I never knew that. One of the things that was really interesting about what she said, though, was that her father came from the wrong side of the tracks. And what's really amazing, my father grew up in rural Mississippi, and he had a horse. So that meant they had a lot. But they moved to Jackson, and that's where we were born. And as an African American, we lived a stone's throw away from Medgar Evers, and where I grew up is now a stone's throw away from a historical landmark. But the reality was that being an African American in Mississippi, no matter where I lived, we were kind of on the wrong side of the tracks. But today I'm going to talk to you because I'm an optimist, and I feel like this is a great time for the work that I've been doing for a long, long time. I'm going to talk to you about achieving health equity and talk to you about it being conscious, planned, and purposeful, and the work that we're going to do today. And I love following Neil because Neil gives us all of these things to think about. My mind just gets full of stuff that I want to take back. And what I want to try to do today is give you some things to take back that you can do, that you can tangibly do where you are and where you work. So I'm going to do a few things. I'm going to talk first about the current landscape of health disparities, and I have to write notes because, as I said, my talk changes, and I don't have a printer, so I'm old school. And then I'm going to talk about what's next for healthcare and why I'm so excited and optimistic about health equity, and then talk a little bit about how we take advantage of this time that we're in. Then I'm going to get this. Make sure I'm going in the right direction. I moved from Washington, D.C. to Seattle recently, and I'm at Seattle Children's Hospital. And in my role, we use this image a lot at work to talk about the work that we do as a center. Because we talk about equality and we talk about all boats leveling the playing field. But if we level the playing field, then people are still drowning. And we're really talking about health equity as opposed to equality, and we're talking about leveling outcomes. And what do we mean when we say that? Well, my goal and my desire is that every kid, I'm a pediatrician, every kid that I care for has their best health outcome. That doesn't mean that they have the same health outcome, but they have the best possible health outcome for them. And how do we do this work? Well, first, let's talk a little bit about where we are in healthcare, in health equity and health disparities work. Unequal treatment, first of all, we'll say unequal treatment, and getting back to what Alan talked about, we're talking about treatment. That was in 2002. And then this is the 2014 National Healthcare Quality and Disparities Report from 2014. And we recently published a commentary in Academic Pediatrics, myself and Fernando Mendoza at Stanford, that said, you know, we haven't really made a whole lot of progress when it comes to child health disparities. It says, you know, the things that we talked about today, it's bad. Asthma, bad. Obesity, bad. Heart disease, bad. Mental health, bad. We're not doing a whole lot, primarily because we're focusing on the wrong things. We're kind of challenged. We're focusing on the process of changes versus the outcome. That picture up there is a picture of the hospital. And this is where we've been focused. When I came to Seattle Children's, we were focused on improving safety and improving the quality of health care. And recently there was publications in JAMA that said, we've made some steps in our processes. We make sure that people get colonoscopies. We make sure that their blood pressure is checked. We make sure that we're using clinical standard guidelines and evidence-based practices when they get into our four walls. Well, the reality is, when I was a kid, I saw the doctor I went to the hospital when I was born. I was born in a hospital, and I didn't go back there for anything until I had my children. So what happened in all of that time? What was the work that was being done? But I did have a lot of people in the community who made a significant difference in my health and well-being, and it wasn't just my pediatrician. One of my role models in healthcare is a gentleman named Aaron Shirley, Dr. Aaron Shirley. He's the first African-American pediatrician to do residency at the University of Mississippi Medical Center in Jackson, Mississippi. He was not my pediatrician, technically. But I tell you, his impact on my life is insurmountable. It's like I'm standing on this stage because of the work that he did in tangible and intangible ways. One of the things that he did was he sat down to lunch with a friend who is an attorney and said, we have this mall that is abandoned in our underserved community, and it's not far from where I grew up. And it's actually the mall that my family shopped in the first time I got lost from my parents at the mall, was this mall. And the mall was abandoned and empty. He said, you know what, we have a lot of people in the community who are suffering from health problems. Why can't we take that mall and do something with it? They took that mall, and it's now the Jackson Medical Mall. And what is that mall? It has health services throughout that mall. It is, they have several clinics. I forget the number of clinics, over 40 clinics in that mall. They have health services, human services, social work. They have patient navigation, but they also have a place where senior citizens can go and walk safely in their community. And my parents go to that medical mall for their care. And they have private insurance and public insurance. It's amazing. But it was the forethought to say, this landscape that's not being used can then be served. And he recently passed this past year, and one of the last things that and he's a MacArthur fellow, he won a MacArthur award, so many awards I can't even begin to name them. And one of the last things that he was working on was community health workers. And he saw the value and the importance of community health workers. And what he was doing was putting them in churches, in rural areas. And you know what he had to fight against? The fact that they said, well, they don't have training to be providing health services. They're taking blood pressures. So we kind of got confused. We're focusing inside our four walls. And the people where things are really happening, where it matters, is out in the community. My mom asks me often, so what do you do? Do you have meetings every day? I said, yes, Mom, every day, several times a day. Because I'm working inside the four walls, but I'm talking about these things about what matters. We're talking about the things that really matter to healthcare. People like me who've been doing health disparities work for many, many years, we're kind of like, they're listening now. Wow. We've been talking about social determinants of health. We've been plodding along for a very long time. We've been talking about food deserts. We've been talking about unsafe communities. How can you exercise when your community is unsafe? And how can you actually make progress when you're in failed schools and you're doing well in school and you're still not meeting the mark to be able to go to college? Or if you get to college, you're having a hard time succeeding because you didn't have the foundation and you weren't prepared. I had the opportunity this past fall to spend time with the Robert Wood Johnson Foundation going around the country talking about data for health, and I'll talk about that a little bit later. But one of the key phrases that someone said out of that process was, we have to get away from what's the matter to what matters. And that's what we need to be working on. Not so much talking about what's the matter. We know what's the matter. We know things are not going well. We know what the data says. But what matters in the community that's really going to make a difference for us? And how are we going to go from these process changes that we're talking about to really impacting on outcomes? And when we talk about unsafe areas, I could really talk to you a little bit about what's going on in this country. And Alan mentioned a little bit about the institutional racism that's going on. But we're all getting fatigued. So I'm not going to go there just yet. Oops, I want to go back. But like I said, I am an optimist. And there are a few things that I like to call the trifecta that gets me so excited about health disparities. The Affordable Care Act and healthcare reform, and the innovations in healthcare technology, and underrepresented populations being early adopters of that technology. And that, for me, is like this place where all these things that we've been talking about, the resources that we need to actually move the needle and make things happen, and to take this place from where your incoming president said and CEO said, we're moving to the place where we want to make health inequity no longer a reality. I think we're talking about not that incremental change that we've been doing on and on and on, but those leaps and bounds. My mom, when I was growing up, we hardly ever spent any time cleaning the house. In my remembrance, there wasn't this, oh, you have to make sure that on Saturday, we're going to clean all day. Sometimes we did that for our kids. It's like, okay, it's cleaning day. Because my mom had this philosophy of, if you do a little bit every day, then you don't have to take your whole Saturday and waste your time cleaning the house when you could be out doing something and spending time as a family. And my mom worked full-time. She was a school teacher, which brought to me my love for kids. But the thing about health disparities in healthcare is we haven't been doing those incremental things. And now we need to make some huge leaps. So first is the Affordable Care Act, triple aim, ACOs. We've been talking about this, they talked about this yesterday. But what I love about this process is that now people are starting to talk about social determinants of health. People are starting to talk about getting outside the four walls and taking healthcare out of that silo. Folks who have been doing health disparities research and all the various iterations of names that it's been over the years, people are starting to knock on our doors. Like, hey, what's that stuff you've been doing, that community stuff you were doing? Those people you were talking to in the community, those organizations, those churches, those barber shops, what's that all about? And we're like, whoa, how you like me now? So yes, the payment structure, there are all sorts of flaws around all of these things. But for us, it's like you're shining a light. Thank you very much. But we're careful because we know about being the flavor of the day. And this is all about thinking about sustainability. And that goes back to that focus in making sure that we're focusing, and why I feel like it is important that I'm inside those four walls, pushing them out the doors. And the next thing is innovation in health and technology. Yesterday, Indu really talked about all of the technology that's going on, all of the great developments that are happening in our hospitals, for the consumer, literally on the consumer. I've got my jawbone. I've got, everyone has that. I have my scale at home that connects with my system, my Fitbit that tells me how I'm tracking. And then in social media. And it all generates this data that in the past, we did surveys that by the time we got the information, it was outdated and we couldn't act on it. And everyone talks about big data. But big data without context is just numbers. Let's be real. But I'm really excited about innovation in this technology because our policies around meaningful use are bringing healthcare together with this data in a real-time way where we can use it in ways that we couldn't before for subpopulations where we didn't have enough information. When we're talking about American Indian and Alaska Natives, there's never enough data in that database to really make any difference. And there's nothing that we can do in a really short, actionable time. So I'm actually excited about the innovations in data and all of this data that we have to utilize. And then the last thing is adoption. So I spend a little bit of time on social media. My family would say I spend a lot of time on social media. And while Twitter in their workforce might look very, very white, the influence online is very, very brown. And what that means is that there's a voice to this community. There's a voice to the impacts of institutional racism. There's a voice that goes beyond the traditional ways that we get information in traditional media. I tell this story, my family was out of the country when Ferguson happened. And my husband is not into social media at all. And at the time, we were sort of like, what's going on? And my husband watches the news. I follow Twitter. And I said, this is an amazing thing that's happening. And he said, oh, well, no, it's fine. I said, no, look, here it is in real time. And it said to me that instantly I could learn something. And it was a social movement that moved us to a place where we were talking about things like Black Lives Matter. We have a hashtag now that we all know about. And we all understand the impact of differences in policing and the risk. And like I said, every week there's something new, to the point where we kind of get fatigued and we kind of get tired and say, how in the world can we actually make a difference in that way? And when we think about community, and when we're talking about community and community connectedness, we have to realize that yes, our community is local, but our community is global. And particularly for minority populations, minority communities, that social community is very, very powerful. I had the opportunity to get an education, to leave my state because of that local community that supported us when we were homeless and when we were in need. But there's a social network and a social community that supports underserved and minority communities, and it's used for social justice now. And it's an opportunity for us to think about in healthcare in how we use that community and how we work with that community in terms of health, and how we tap into that leadership. So I want to be specific in what we can do. So what can we do specifically to help in our communities? What can we do to address health equity and not just move the needle in incremental ways, but in leaps and bounds? So the first thing, yesterday, James talked about understanding what the executive in the hospital system, what mattered to them. And so I started this with talking about practice, but then I said, first we need to really be practical. I came to Seattle from Washington, D.C. It's a very, very different community. As my daughter loves to remind me, she said, Mom, there are 7% African Americans here. But the reality is, and if you're doing health equity work and you've primarily worked with African American communities in the past, you're kind of going, what? But and data just came out recently that said Seattle is the whitest urban community in the country. Wow. But the reality is that Seattle and Seattle Children's is an evolving community. I have a wonderful colleague who's doing transformative cancer research. And he has a phrase where he says, look at the amazing things we're doing in this little fishing village. But the reality is that Seattle and the surrounding area is now a global village. For our hospital, 1 in 6 of our distinct patients last year, so that means 1 in 6 of the patients who walked through our door preferred a language other than English for their care. 1 in 6. So, and that doesn't include the family around them, their community, the people their parents who walk through the door. That's the patient. 1 in 6 at our really white Seattle Children's Hospital. Because numbers can be deceiving, as we know. Because we can talk about the healthiest community with the unhealthiest people right inside those same geographic areas. So for me, it's really about looking at how can we build a culture of health equity at Seattle Children's Hospital. That's my task. That's my job. Because I don't want the work of health equity to be siloed within a center. Health equity is everybody's job, from the person who greets the person at the front to the surgeon who's providing care in the operating room. And what I want to do is say that this is not a fly-by-night thing, both in the work that we're doing inside the healthcare system and as we work to push and break down the boundaries and the silos of healthcare and health. It's everybody's job, so that we're not talking about it here and here. We're talking about, how do I think about my work in a way to make sure that my policies, my practices are not contributing to a difference in health outcomes for the patients and families that I serve and for my community. So that's what I do inside the four walls. But then let's talk about partnerships with the community. And this is not a health-related group. Black Girls Code is something that was started by an amazing former, she's not a former engineer, an engineer by the name of Kimberly Bryant. And it's a model for us to think about in healthcare. She decided that there was something missing. There was a need for science, technology, engineering, and math. There was a need for an understanding of coding for Black girls. And she said, I want to create a program. And the reason she did it was because her daughter couldn't find a place where she felt comfortable because she was interested in coding. Her mom was an engineer. That's what they do, these engineer people. And so she said, I want to create a safe space for my daughter and other girls like her to learn because they're our future. When we talked about all that technology and all that innovation, it's like when we talk about venture capital funding, the funding that actually makes that happen, the wheels that make it turn, only 1% is for women. You know, less than 1% is for minority developers, minority startup companies. So you have to think about that. But what she did was she said, I want Black Girls Code to be the Girl Scouts of coding. And what did she mean by that? Because when you're a Girl Scout, it's all about the community. It's all about each individual community having a chapter, and that chapter builds around that community and does the work. And so Black Girls Code is not just all over the country now, it's all over the world. Because anyone can pick up and say, I want to work with Black and brown girls in my community and teach them how to code. And you know what those little girls are doing? They're creating solutions for their communities. And that's what this is all about. Having communities create solutions for themselves and investing in themselves. Because that's why I'm here on this stage, because a community invested in me. And how do we think about doing that in healthcare? So I want to tell you about some work out of the University of Chicago called Community RX. And Community RX was started by Dr. Lindau and her group. And basically what they do is first they start by partnering with the community for a program called MAPS Core. And I'm going to go back because I want to make sure that I get the name of MAPS Core, what MAPS stands for. So it's MAPS, it stands for Meaningful, Active, Productive Science in Service to the Community. And what it does is it reaches out and it identifies youth in the communities that they're working with. And they've done this in Chicago and New York. And they have those youth go out with college-age mentors with their smartphone, and they identify assets in their community, boots on the ground, walking up the streets of their own neighborhoods to understand what are the resources there related to health and related to social services around health. And they put it in their phone because that's what teenagers do. They put it in their phone. They have an app for that. And then they take that information back to community health workers, and the community health workers call those companies, those businesses, those organizations to get more information about the resources that are there in this mapped community. Then they put all of that in a database. And that's where Health RX comes into play. Because then providers can prescribe Health RX to their patients. You have diabetes and you live here. Oh, let me pull up the resources in your community that have been identified by people in your community. And then I'm going to connect you with a community health worker in your community to help you navigate those resources. Amazing. One of the things that we learned through the Robert Wood Johnson Foundation Data for Health initiative was that data moves at the speed of trust. I'm an academic, all that research stuff, yeah, I do that. And one of the studies that I did, we asked the question, what was the thing that helped people to communicate with their provider? What were those key things? One of them was trust. And we know that trust makes a huge difference. Do I trust my provider? And the second thing was self-efficacy. And what does that mean? It means, am I confident enough that the goal that I have set for myself in going to that visit and in that interaction, that I can achieve that goal? And so what these things do is it provides that information where we can then say, I have resources from a trusted source in my community, and I have confidence that I can get the things that I need and follow the instructions the doc gave me. And then the last thing that we talked about is policy. One of the amazing things about going to Seattle and that made me excited about moving to Seattle is this whole idea about health equity. It's not just a new thing, and it's not just within the healthcare system. It's at a policy level. And Seattle King County invested in health equity, in equity and social justice. And as we know, those social determinants of health happen outside the four walls. But if you don't have any impetus and any motivation and any glide path and resource to bring all of those things together, then we're still going to be in our siloed areas, and we're still going to have healthcare here, and we're going to have social services here, and we're going to have housing here, and we're going to have transportation here, and all of those things are things that we need, because the reality is when I had challenges with my patients being late, the problem had nothing to do with their lack of effort. It had to do with the fact that the buses were running late. So what Seattle King County did was they said, we're going to look at everything. We're going to look at access to health services. We're going to look at neighborhoods. We're going to look at that early child development, because we know investing in our children matters. But we're also going to look at transportation. We're going to look at our justice system. We're going to look at access to healthy foods. And we're going to look at access to exercise. And we're going to work on removing those barriers so that there can be greater access to those things that are the real determinants of health. And then we want people to be happy, that happiness index, and we want people to thrive. And that's really what it's all about. I find that people think that people with less resources are not happy. That's just not true. We try to tell people they're not happy, but they are. But the reality is we want to decrease the burdens that prevent people from thriving. And that's the work that we're going to talk about today. And I have to end with a quote because we talked about quotes yesterday. Story quote. Of all the forms of inequality and injustice in healthcare is the most shocking and inhumane. And that was from Dr. Martin Luther King Jr. And we really have to think about moving away from, as Alan said, our silos of health care to thinking about health. But we also have to be really, really careful as we're looking at ACOs and we're looking at this, we're the healthcare system and we're going to create health, and stop and go the other way. One of the things that I talk a lot about in my organization, and I have 30 seconds or a little bit more before I close. I don't know if anyone's seen the Planet of the Apes. Anyone in the audience? The young people, maybe the new Planet of the Apes, not the old one. So Caesar is the lead of the apes in the second one. And when they get in, they have an agreement. Ape does not kill ape. And that's an agreement that they have. And then Caesar gets into a disagreement with one of the other apes, who is the one who ends up rebelling. But he beats him up really bad, and then he stops himself. But what they do when they're trying to make amends is that the ape comes to the other one, and he does this. And he reaches his hand to be received. And what I tell my organization all the time is that we've been doing a lot of reaching down. And what we need to do now is humble ourselves and reach up to the communities that we're trying to serve. And realize that we're in service to them. They are not in service to us. Thank you.
Okay, now you get a real break. We are a little behind on schedule. We'll reconvene 10:30 promptly. Come back in 15 minutes.